100 deliveries every year because of what? Because of course, majority of them will die. But now, my point is, PPH contributes to almost, what is the percentage of PPH in that 355? Are you getting my point? My point is, how much is PPH contributing to the overall maternal mortality? Do you know the numbers? Because now if we want to sit here for 2-3 days to learn something to do with prevention of maternal mortalities and prevention of PPH, we have to know the number of which we are talking about. Because now if it is just a vague number, we don't know what we are talking about, it's going to be a little bit difficult. So generally, 35 to 60% of maternal mortalities are because of what? Of PPH. Isn't it? Now, I just want us to have a comparison. In UK, for those who are doing a little bit of study from developed and developing and the developed countries. In UK, these guys are at around 12.4 per 100,000. Us, we are at 355. So you can see the gap. Isn't it? We still have a very long way to go. Okay? I'll come back to the UK badai. Now, let's compare PPH with other causes. But before that, we want to see the 355. You might look at it as a small number, but compared to the other causes of deaths generally in our country, it is 1.6 times more than all the traffic accidents which happen every year. So for example, last year, 2023-2024, we had around 2,400 deaths. 2,400, 2023, 2,500, 2025, deaths caused by road RTAs. So if at PPH, we are 1.6 times more than that. So you might look at it as a small number at in 355. But when you explore inside and check on the numbers, the real figures are very scary. So generally, the 355 per 100,000 looks simple. It's not a lot of people. We are at Coast General, maybe in one day we deliver, I don't know how many, 50, 60, they go home with their babies. But ukiambua 355 in 360 days in a whole country, it might look small, yes. But generally, if you go deep into those numbers, it's not at the whole population. It is per 100,000, okay? So if you are losing 2,400 for RTAs, it is 1.6 times what we are losing in our hospitals, okay? And majority of those ones, as you said, almost 60% are secondary to PPH, okay? Now, second point, I'm going back to UK. I said UK, they are only losing 13.4 per 100,000 per year, okay? Us, we are at 355. You know, the main cause of deaths in those countries, who can guess what is the main cause of maternal mortality in UK? Just a try. First of all, you should know that UK doesn't do maternal mortalities every year. Hawananga hizi mikutano zetu za, I don't know, MPDSR every week. Those guys, even the last report was 2020, 2021, 2022. They had combined almost 3 years to make one paper. And then still, the people who died in all those years, the figure is even funny. Trust me, they are less than 50 in those 3 years. Anyway, first of all, the main cause, even including, you know, it was 2020. So we have deaths which were attributed to COVID. Okay? So if you remove the COVID-related deaths, things which were, the main cause was actually VTE. VTEs too. The embolism, venous thrombolytic embolism. Those are the things which are killing them. And then the worst thing, which I'll tell you is, majority of the people who died, even those 13.4, 40% of them are black. You see? So it means, PPH kumbe, maternal mortality inatupenda sana. It's our thing, it's here to stay. And then let me tell you, what is the second category of people who died? In those, I don't know, 13.4%. Say 40% were around blacks. And then next to them were mixed race. So even if you're not a black, but you marry to a black, and being there around there also was a risk. Okay, so I can say, generally, when you are living in a failed system, when things are not being done the right way, probability of you encountering these things is very high. It's as simple as that. Okay? So, why do we care? Why do we care? Why are we here talking about PPH? Okay? We are losing mothers, isn't it? 355 is not just a number. Those are mothers. Those are people who left their homes. They were happy. The husband was there saying, today, nikirudi jioni, we are coming back 3. And then unfortunately they come back 2. Or they come back, only the husband comes back. Eh? Isn't it? So it's not something to say, it's normal. It's not normal. Okay? More so if it is something which is preventable. So we do care about PPH. Now, for the midwives, there's something very important about it. Very, very important about it. Midwives are often the first and sometimes the only people who are available when PPH starts. Sometimes it has an away and it ends with you. Isn't it? We know the problem of poor staffing. So of all those things, tutazungumza baadaye, the reasons and what. Poor staffing is one of it. And those people who are working in the rurals, and your midwife, she's the one to cut the cord. She's the one to go for uterotonics for the syntocinon. She's the one to inject. She's the one to do the hamsters. She's the one to massage the uterus. She's the one to resuscitate the baby. She's the one to bring hot water. She's the one to clean the floor. She's the one to go to the pharmacy and take. She's the one to do everything. Cynthia, true or false? Yeah. So because of understaffing, you have to know that the midwives, most of the times, they are the only people who are available. So if we empower the midwives, then automatically we are going to reduce the maternal deaths. And of course, as I've said, 14 million women experience PPH annually. 14 million is not a joke, bana. Hey, those are too many people, okay? So just imagine you are in Mombasa or you're in Kakamega or in those places where everything is available. But there are people who are in areas where even assessing the uterotonics, even having, delivering under the hands of trained midwives is a very big challenge. Last time I was talking to someone about the difference. I don't know why I like using these developed countries examples. These guys, they are past what we are talking about. As in, they were talking about PPH like 50 years ago. They were talking about, to them, PPH is no longer a problem. The problem is ours. But the only thing between us and them is we don't want to learn from them. What are the things they did to make sure that a woman will not... If you look at that chart in UK or in US or other developed countries, you'll see PPH iko chini kabisa huko. In fact, people are actually dying because of diabetes in pregnancy, more than, or sepsis, but not PPH. PPH is down there. And then they say that, in those countries, you can deliver they have 4, and I think most of you know that. You can deliver at home, you are given that option. Cynthia, you can deliver at home. You can deliver what we call the standby midwives, those centers. And then the last one is when you deliver in a hospital where there's a gynecologist there. So someone is actually being given the option of delivering at home. Sisi tunakimbianga TBS, those people are being given that off. Simply because in case of anything, in fact, let me tell you, honestly speaking, the outcomes in those women who delivered at home and those who delivered under midwives, standby midwives, even midwives are divided into 2. There's those centers with the midwife inside and then those centers with the standby, okay? So those ones actually, they have, and the outcome is good generally, but they are advantaged, the probability, actually, this is the word, the probability of them undergoing a cesarean section, their babies undergoing vacuum is very low. The only problem, I think, there's a slight increase in the neonatal outcome, comorbidities. And morbidities on the neonatal outcomes, they are slightly higher if you deliver at home, of course, or on a midwife standby homes and those things compared to when you deliver in the hospital. I don't know if you get the point. But generally, the outcome for you, if you deliver at home or you deliver in those standby midwives, you have almost the same outcome with the person who delivered the hospital. In fact, the person who delivered the hospital has high risk of undergoing a cesarean section or a high risk of having their baby being pulled by instrumental deliveries and all those things. You see, because the systems are very simple. I'm trying to deliver, I can't deliver, things are bad, I can't go anymore. The ambulance is out there. You are taken to the hospital. In the next 10 minutes, you're in the hospital and things are done. Isn't it? Kuja huku kwetu. You are in the hospital. I'm not talking about ati uko home. And kinaumana. You are in labor ward. And you start having PPH and things go wrong. You are in theater and you're having PPH and someone cannot help you. You see? So when the systems are actually working, majority of these things are preventable. Because there's no way you can tell me, these guys, are they having, in I don't know, 2-3 years, they have mortality of less than 50 people, and then us, in 1 month, to show, I don't know, 100. There's no magic in between. So these things are preventable. We just need to know where to touch, what resources to pull, whom to address, whom to train, okay? And then everything is going to be okay. Okay, so my last, actually this I've talked about it, that 28% of the, what kills our women? So 28% of those deaths are secondary to pre-existing conditions. We have like diabetes, HIV, obesity. We have blood clots. So in our country, blood clots are like 3%. Those guys here 3% and then apatia headache huko kwao. They're like 16, I don't know, 18% after COVID, of course. And then abortions, complication, obstructed labor. Obstructed labor in those countries that it doesn't feature anywhere. How can you obstruct, for heaven's sake? You want to obstruct sangapi? Yani inafikaje the diagnosis of obstruction huko, it is long forgotten. No one even unapata obstruction paka unapata fistula. Seriously, in 2025. Yeah, that's a very big sin. Okay? Okay, and then so severe bleeding, of course, the hemorrhage, and then we have around 14% PET. Now, so it's important to check on this slide. Sometimes the demographics might change. There are some places here in Kenya where they have pregnancy-induced hypertension is slightly higher compared to other causes. There are places where sepsis is a little bit higher compared to other places. For example, places where we encounter a lot of abortions, especially the induced abortions, you have vichochoroni, they tend to have a lot of sepsis part goes up. Okay? There are places where the PETs, it's higher compared to others. Like at the end of the day, hemorrhage is still number 1. Okay? So if we know hemorrhage is still number 1, we know how to prevent it. We know who is supposed to be there and what is supposed to be there and what are the things we should put them in labor ward and 1, 2, 3. Once we learn all those things and we have them and our midwives have been empowered, it's very simple very, very easy to prevent those deaths. So the normal definition, what we call the traditional definition of hemorrhage, we know there were 500 versus the 1 liter. But we said this is an old one, an old definition. The current definition is we check much on the symptoms, sindio? Ama bado tunaangalianga 500. And then awananga hizo ma V-dreps, wanasema hii ni 500, hii ni 200 hii. Si mmeambiwa muassess hapa mtaangalia the errors you always make. We always underestimate, okay? So at least now we have the V-dreps, we have a lot of facilities to quantify, okay? Objectively and not subjectively. So we still stick to the symptomatic part because majority of those who are in coast region, they know majority of our patients come with the HBs of around 6, 7, 8. Hiyo ndo disco yetu tunachezanga hapo. So if you want to lose 500 mils, ndio sema ni PPH. My friend, tutakuwa tunaonana mog. You can't I've delivered a mother with an HB of 5. People have delivered an HB of 4. The worst I've had is HB of 2. Nada ameona HB of 2. By the way, HB of 2 in course they walk. They walk and they have fun. Trust me, they don't just walk. They walk, they laugh, and they have fun. And they're pregnant. And they'll come in labor. And they'll come in second stage. And they'll have not gone even once for antenatal. Mungu tusaidie. So, we know the etiologies, the 40s, sindio? I won't dwell much on that because the whole workshop is about PPH, the 40s, the what, and all those things. So I think I'll stop here And if there are any questions and queries, if I'll be given 2 minutes, I think you can ask. MC ako wapi? Nimemaliza bwana. Mkiacha niongee, itakuwa baridi. Thank you. Asanteni and thank you for your time and see you during the breakout sessions.
Thank you so much, Doc. Let us give him an organized. Simama hapa upewe zako, si ndio? Aha. Naomba mmoja wetu aweze ku-appreciate daktari kwa ile kazi amefanya, si ndio? Alisema yeye ni mganga mganga bingwa. Ukisema wewe ni mganga huko kwetu tunakuangalia hivi. Na unajua mimi kwa majina naitwa Mwana Helena. Sasa mwana mwingine kama mimi aweze ku-appreciate daktari. Baby girl, come and appreciate him. Umefikiwa leo.
Nuru appreciate me.
Amechagua Nuru.
I know God appreciate me. In this forum, sister, there are people who taught me how to
do this thing.
Conduct SVDs here.
That is great.
So I have my mentors here. I have my sisters. I have people who taught me a lot.
Are you not proud that you made a very good person here? Let us appreciate ourselves for that first before Nuru amalize hiyo kitu. Sindio? Thank you midwives for doing that.
There are people here who made me love obstetrics. And
So you created a good environment for our doctors, Sindio? So that is how much we can do it now. And I know when midwives also decide to do that other thing, they can frustrate. Until they change their profession. Instead of helping mothers, now they go for the bones. But I want to appreciate all the midwives who are behind these able people. And that's why he's before us doing a wonderful presentation. Nuru, please, he's inviting you in front to appreciate him. Let us also appreciate Nuru for that. Senior. Thank you so much. Karibu.
Mpaka lete vituko vyake hapa. Sawa vile ni mganga hodari. Wacha tumtafutilie maua. Tukusanye maua. Tukusanye maua, vilua, asmini, mawardi yote mlalangi.
Lakini umekrashio maua. Asante sana. Thank you so much, Doc, and thank you for enlightening us to know where we are. And the team, there is something that we can do to help us prevent PPH that is really harvesting the lives of our mothers. At this juncture, I wish that we break for tea. Did we pray for tea when we were starting? No, we didn't. Sindio? So we need to get a volunteer to pray for this tea. I don't know whether we are all aware where our washrooms are. They are just around, so you'll be able to also balance the input-output. Meanwhile, can we get someone to pray for the tea? Oh, someone has been selected. Sister, pray for the tea, please. Come. You never know why you are being chosen amongst many, just to pray for this. Thank you.
Let's honor our God and stand up. Katika jina la Baba, la Mwana na Roho Mtakatifu, tunakushukuru, tunakutukuza. Mungu wangu, tunapoenda kutumia kikombe chao kitakasa, ukibariki. Baba yangu, tuko hapa kwa ajili ya upendo na mamlaka yako. Utuongoze katika kila jambo, kwa kuwa wewe ni Bwana, na ni katika pendo kula Yesu Kristo nimeomba na kuamini. Amen.
15 minutes starts now. Tea we take in I think there's the other floor. So let's go down. Join me to welcome our second presenter, a lady from the land of bread baskets. Wanasema huko kwao chakula ni mingi sana. It's the Canaan in Kenya. So let us join all in welcoming Esther. Thank you. Karibu sana Esther.
Thank you, Helen. Good morning. Is it still morning? We want to look at RMC, or respectful maternity care. And I think we've interacted with this, sindio? Either kama disrespect ama kama respect. What do we mean by respect? Respect is a behavior that brings about dignity and the value of the other person. What is disrespect? And disrespect goes with abuse. It is the opposite of respect. So today we want to focus on respectful maternity care because we have interacted. And if I go around asking you, who has ever witnessed disrespect? By show of hands, who has ever witnessed disrespect in their working area? Thank you. So a few of us have witnessed disrespect. And as we discuss, you'll see that we have all witnessed disrespect. What is this we call disrespect? Disrespect is when you give a care to a client and that care compromises their dignity. True or false? Yeah. So some of those things, I just want you to look back and reflect on your care. Try to think at any point you saw or maybe you took part in this disrespect. Sometimes it's carried out knowingly or unknowingly, okay? And we find that respect is the key or the foundation to any good relationship. That for any relationship to exist, there must be respect between the parties. And as midwives, we are supposed to maintain or observe respect between us and our clients. What does a respectful maternity care do? We find that it is important because it builds trust between the client and the healthcare provider. And we find that even during a complication, that RMC should be observed. I want you to think about this time when there was an emergency and nobody was communicating to the client. That people were focused on the emergency. Do you remember such a time? That the goal here is to save this woman's life. The relatives are there. The client is there. She's bleeding. It's a PPH. And nobody is telling them what is happening. We are just, Mama, fungua mguu. Mama, geuka hivi. You know, she's turning, but she doesn't know why she's turning. She doesn't know why this and this is being done to her. So, if you ever saw that or if you ever took part in that, that was disrespect. Yeah? So, in respectful maternity care, we insist on the client being informed of what is happening to them. We insist on the client giving consent, yeah, informed consent. Sometimes we find ourselves in a situation where you're like, Mama, nataka nikudunge shindano, so you don't even tell me what the injection is about, and I just say yes. But in respectful maternity care, I want to give you this injection, inaitwa oxytocin. Itasaidia kupunguza kiasi cha damu ambacho kitatoka kwa uzazi wako. So that is what respectful maternity care would call for. And we find that when women are treated in a respectful manner, that they are able to make choices, they are able to appreciate whatever is happening to them, and they feel very safe. Imagine when people are just turning you, doing this and this, how will you feel? You feel uncertain and anxious because you don't know the next thing that is likely to happen to you. So it is important we do that. So even in emergencies, we are emphasizing that even in emergencies, that there should be somebody giving feedback, somebody ensuring that there is dignity, there is privacy, because some aspects of disrespect include privacy, abuse, lack of confidentiality, both audio and visual. Yeah? Are we thinking in terms of audio privacy? Audio privacy would mean what? That the next client, yes, is very much aware of what is happening to this other client, because you're speaking so loudly, okay? You've not protected, or rather minimized, the sound transmission to the other side. Disrespect in emergency would entail what? You call for help, PPH, and you don't inform your client that around 10 people will be coming. Do we do that? And you're just in your mind, the priority here is to save this woman's life. So as we learn along, this respectful maternity care and good communication is part of the emergency care that we would like as midwives to give our clients. And it means that the moment you shout for help, you have to let this woman know that Mary or Amina, I'm going, you are bleeding heavily, and I need to assist you, but I cannot do it alone. I need to call other people. So you are going to see so many people here. Do you give consent? Yeah? Sometimes they would want to resist because I don't know what your culture is here, but there are those private moments when you don't want so many people to see you. But if you explain to her, you will get informed consent, not forced consent. Do you know the difference? Forced consent, informed consent. There is that forced or coerced consent where this woman has to oblige because, you know, what do I do? But there's the informed consent where she will accept because she knows why the 10 people have to come and help in her management. Okay? So that leads us to something else, communication. And we understand as healthcare workers, as midwives, that effective communication is very key in emergencies like PPH. I want to give you a scenario. Long time ago in a facility, before the nurses and midwives were empowered, there was this scenario. There's the nurse in the ward, and she calls. Okay, she's called by the caretaker or the relative of the patient that my patient is bleeding. Sister, come and see this. So when she gets to the client, okay, she finds the patient bleeding. What is the next thing to do? Call, okay? And she calls the doctor. And kule kwa daktari, there's some noise. I think it was a Friday and maybe the doctor had gone to like have fun, eh? It's allowed, eh? So a doctor called, some noise heard in the background, okay? And then again, after around 10 minutes, doctor called again, patient still bleeding, doctor called again. See, communication was taking place. Yes, she kept calling the doctor, and she kept doing what? Documenting. Would you guess what happened 2 hours later? Yes, this patient did what? Before the doctor did what? Arrived, eh? I'm not mentioning any facility. That is just a story from some facility somewhere. But those things have happened, and patients have died. I need support. Patients have died while we are documenting effectively. So I'm just looking at the other way of it, that if this midwife or nurse on the ground, one, if she knew what to do, maybe to address that PPH, yeah, which we are going to take you through today, if she knew what to do, or if she knew that she can call any other alternative person, maybe this patient would not have done what? Died, yeah? But she did her work so well. Don't you think so? She was documenting and reporting the outcome of the call, okay? So communication can go either way. It can go. So communication can go either way. It's the charge, yes. So communication can go in a negative way or a positive way. Positive communication will bring good outcomes. We want to look at PPH, and today we are talking about a PPH mainly, looking at the emotive bundle that we are going to be exposed to. In an emergency, good communication is key, okay? That once you call the team that comes and you shout for help and everybody comes, the communication has to be clear. I want to give you another scenario where everybody is communicating. That mmekuja, Amina has shouted for help, yeah? And then everybody comes and everybody is giving the commands. What will happen? Have you fixed the granula? Somebody else is saying, have you put the fluid? So again, during an emergency, the roles have to be clear. The roles have to be communicated clearly. Thank you. The roles have to be communicated clearly, and everybody must understand what they are supposed to do. So communication must be respectful, and we are going to look at different aspects that it will help us maintain good relationships amongst the team members and also the family of the client and with the client when the communication is good. We are going to look at the ESBA approach. We have added I to it, and now it is I-ESBA. I-ESBA stands for introduction, introduction of self, introduction of the other parties involved in the communication. It stands for situation, it stands for background, and assessment and recommendations. How many have interacted with I-ESBA? Good. So we are going to look at each of the components of I-ESBA. What does introduction mean? It means that you introduce yourself. For example, if I call you, I should be able to say, this is Nakoche, calling you from Kitale, yeah? And I'd want to ask, who am I speaking to? So the other party will know who I am, and I'll be able to know who they are. Sawa sawa. Are we together? Tunalewa ama tunaelewa? Tunaelewa na tunalewa. Thank you, thank you. Thank you for being with me. And then we have the situation. The situation is what? The situation communicates in a nutshell what you have at hand. Okay? That if I call you and tell you that I am Mariam, and you tell me you are Amina. So I tell you, Amina, we have patient X who is bleeding heavily after delivery. What have I communicated? What is running through Amina's mind? PPH, okay? So from a glance, from your communication in the situation, the other party should be in a nutshell able to know what you want to communicate to them, what information. Their antennas, as I like saying, should begin leading them to some place that this is PPH, this could be PPH, and they begin to anticipate management of the PPH, okay? So then we have the background. Background is going to give us what led to this situation that we are having at hand. The patient X is bleeding. What happened? So this patient delivered 2 hours ago. We administered, we did arm still, and after that, it is 30 minutes after delivery, and the patient is bleeding, okay? So the background, assessment. What have you done? What assessment have you done? On examination, she looks pale, okay? On examination, the uterus feels boggy. So examination is your findings at the time of assessment, okay? Or assessment is your findings during the examination. What recommendations do you want? Maybe you are calling theater. So R stands for recommendation. You are calling theater and you want them to do something. So I'm calling you because I want to refer the patient. We have instituted all the mechanisms of emotive. We have done this. We have massaged the uterus, given uterotonics. We have given tranexamic acid, and the patient is still bleeding. So we are escalating. And now, because you are escalating, we'd like you to receive this patient and institute the next level of management. Sawa sawa. If you are with me, clap once. Thank you. So we find that in a good communication, respectful communication, we use closed loop communication. And in closed loop communication, what do we mean? We mean that when you communicate, you should get a feedback and you should acknowledge the feedback, okay? So why do we use closed loop communication? We use this to prevent any mistakes or any barriers that would occur in the course of communication. In an urgent situation, the team lead may ask somebody to perform a task. For example, the team lead can ask Precious to start an IV fluid of Ringer's lactate 500 ml and infuse as quickly as possible. So this is how the communication will go. Polycarp, are you going to be Precious? So Polycarp is going to be Precious so that you capture exactly what we want to communicate. So nikuite Polycarp ama nikuite Precious? Precious. Okay, so Nurse Precious, please start an IV with Ringer's lactate 500 ml and infuse it as quickly as possible.
Yes, so thank you. So I will start an IV with Ringer's lactate and I will infuse it as quickly as possible as you have directed.
Yes.
Guided.
So have you infused?
Yes, I have infused.
Okay.
Yes.
So again, Polycarp, if Precious if not clear, will ask me, did you say that I start an IV? And then I will say yes. But if they are clear, they will go ahead and report what instruction I have given. So this, when this is shouted out in the team, it will prevent replication of that particular role by somebody else. So we call it checkbacks and closed loop communication, okay? So we have looked at that. And in a nutshell, we are saying that in respectful maternity care, we must observe respectful communication. And respectful communication involves IS-bar, and we've gone through the components of IS-bar, and it also involves using closed loop communication in which we get feedback as we give communication. I don't know if you have any questions. Mumelewa sana ama mmelewa kiasi. So thank you for listening to me.
Great. A round of applause for Esther. Thank you so much. You know, when you teach and nobody wants to ask you a question, you remain asking yourself, have I really delivered? Has she delivered? Thank you. I hope now back at home, back in our various places of work, we are going to show our clients respect and we are going to communicate effectively to get a good outcome. All right. I think at this moment, we are bringing our next presenters, our next facilitators. We have two Yes, we have two presenters. And I'll invite Polycarp and oh, I'm sorry for that. Thank you. Yes, I was almost skipping some slides. Let us join our hands together to welcome Dr. Caroline Kerubo. Karibu sana, Doc. And she's going to take us through PPH prevention. Karibu.
Thank you. Good morning. Is it morning ama ni afternoon? Ni morning bado, si ndio? Good morning. Muko salama. We've had tea, now we are brighter, right? Ama tuko usingizi. Sawa sawa. So we have learned through Dr. Shaban about PPH and just gotten a status report of PPH and why PPH is an important aspect for us to address. And we have also learned about communication and the way we are supposed to, talk to our clients, communicate with other healthcare team members. Now we'll move from communication and go back to PPH. So we've seen that PPH causes more than about three quarters of maternal deaths, and surely that is something that draws our attention, and we as midwives and other healthcare workers need to work on. So one of the first and most important strategies that we look at in PPH prevention is active management of the third stage of labor. Sindio? So that is one of the most important strategies that we implement when we want to handle PPH, because we want to prevent postpartum hemorrhage. In management of a woman during labor and delivery, when the woman has already given birth, then we anticipate that there are certain things that we need to put in place or we need to do so that we can prevent bleeding. It is not like in the past, or it is not like when a woman accidentally gives birth in a bus or on a train. It becomes different when we have the woman in a healthcare facility, because then we have to be proactive, and that is why we are doing active management. So as we commonly call it AMSTEL, active management of the third stage of labor reduces the incidence of PPH by about 60% without any significant increase in the cases of retained placentas. So when we implement AMSTEL, it helps us to reduce the quantity of blood that a woman loses in childbirth, and it reduces the need for blood transfusions. And therefore, it should be included in any program intervention. So wherever it is we are working, if we are educating, if we are working with programs, then we need to really stress on the importance of active management of the third stage of labor. Now, AMSTEL has a number of components. We will talk about 4 key components of AMSTEL. The first one is administration of a uterotonic. These are drugs that help to contract the uterus. And we have various drugs that can be administered as part of the management for AMSTEL. So commonly, we have interacted with oxytocin, that is 10 international units, which we administer IV. And then in the recent few months or years, depending on the county that you're working, we have talked about carbetocin. How many of us, by show of hands, have heard about heat-stable carbetocin? Show of hands. Very nice. How many of us have used heat-stable carbetocin? Very nice. What is the common name that we call heat-stable carbetocin? What do we call it? Kausha. And it is because of experiences from people who have used heat-stable carbetocin that it significantly reduces blood loss after childbirth. So we have several uterotonics that can be used in active management of the third stage of labor. Now, the second component, we will look at those uterotonics later. The second component is delayed cord clamping. When the baby is born, importantly, is once the baby has been born and you're helping the baby breathe, we have confirmed there is no twin or there is no other baby, then we administer uterotonic. And then we don't rush. Unlike in the past, you know, when we were younger, we would be trained as soon as the baby is born, cut the cord. Is that what we do now? Cutting the cord, is it an emergency? So clamping and cutting the cord is not an emergency. So let's handle it pole pole. The baby is born. We do other interventions to help the baby breathe and to administer the uterotonic before we even think about clamping and cutting the cord. So cord clamping and cutting should be delayed, and ideally we have about 2 to 3 minutes. Different recommendations will give different timelines, but the clamping should be done within 2 to 3 minutes, or sometimes even after the cord has stopped pulsating. And then the third component of AMSTEL is delivery of the placenta by controlled cord traction, and this is for all women. And then finally, after delivery of the placenta, then we conduct a uterine massage. Important to note is that administration of a uterotonic remains the most important component of the active management of third stage of labor. Sindio? Kwa labor ward zetu, which facility is the busiest labor ward hapa Mombasa? In the coastal region, the busiest labor ward or maternity is Coast General, right? In a day, how many women can give birth? We can get to 10? We can get to 10. So we have to be proactive so that by the time a woman is getting into the second stage of labor, then we know that we have oxytocin or carbetocin, whatever uterotonic we are using, ready so that this woman can be injected within 1 minute of birth. That is the most important aspect, the administration of the uterotonic and the timing with which the uterotonic is being administered. So we will look at a video, I hope it plays here, that will briefly it has refused to play. So there's a video we wanted to show on active management of the third stage of labor.
Kusoti.
All right, we are back, so we can. Hi. Are we okay? Have we said hi? Very nice. So we can come back and watch this brief video on active management of the third stage of labor. Sorry about that. We will redo for voice purposes. Nini imefanya ile kitu? Technology. So as the video is playing, I would want us to do just a small activity within the tables that you're seated. As this video is playing, you can note down something important that you have seen being done in the video, and then note down something that is different from what you practice in your health facilities. So what you are seeing that is different, and what you have seen that is important that you have noted as we look at the video on active management of the third stage of labor. Is that okay? Okay. So because the sound is low, I will replay, then we will just listen and watch and pick what we are able to pick from there.
This gives the baby his full iron stores and prevents anemia. Here is how to do controlled cord traction safely. Place your hand just above the woman's pubic bone to hold the uterus back. With your hand lightly on the cord, wait for a strong contraction.
Okay, so we have seen a video on active management of the third stage of labor. I had asked that we note down a number of things. So maybe I would want to get feedback just from two people. The first one I had asked is what it is that you have picked from the video. We can get somebody, a volunteer, to tell us what you have been able to pick from the video. One thing. Anybody? Yes.
It's still morning. Good morning. Zaro Dennis. So what I was able to pick, there were two scenarios. There was one midwife that did not apply the control contraction that is supporting the uterus while pulling the cord. Yes. So in that video, like we saw a lot of blood. There was a gush of blood, and compared to the other healthcare provider that provided support while conducting the controlled contraction.
Thank you so much. Let's give him one clap. 1, 2, 3. Very nice. So I would want one other person to tell us something that is different from what you saw in regard to practice. What do you practice differently? Let me see if we get another hand from another table. If we don't, then I'm coming back to this table. Anyone from the tables at the back? I'm a backbenchers walikuwa melala. Any feedback? What have you seen that is different with regard to practice or resources from the facilities you work? Yes, there's someone at the back.
Yeah, thank you for the opportunity. This is Momin from Kakamega. Okay. What I saw differently is on resources. They are still using a string and a normal blade other than the cord clamp scissor and a cord clamp that we provide at the facility. Otherwise, most of the things like delayed cord clamping, massaging, everything was done well, except the resources. Thank you.
Thank you very much. I am tempted to stop there, but maybe we can give just one more person an opportunity to mention one thing, then we will continue. We'll still have chances for us to interact more as we proceed.
Good morning. I'm Elizabeth from Kitui County. We saw that she withdrew oxytocin earlier and put it on the table. That one can interfere with the cold chain.
So thank you, Elizabeth. So one of the things we have picked is what it is that is good practice and what it is that can be improved on, right? Yeah, so if you're talking about oxytocin and cold chain management, oxytocin is distinctly recommended to be used within specific temperatures. If the oxytocin would have been withdrawn much earlier and left on the table, then you'd be concerned. But if it has just been withdrawn at that exact time and may not have had, a significant change in the temperature or the duration from withdrawal to administration, then that would be something different. Also, we will note the video was done a few years ago when we did not have other options like heat stable carbetocin. Importantly, also, this is to also alert us that it doesn't matter where we work, even in a resource-constrained area, it is still possible for a midwife or for a healthcare provider to perform active management of the third stage of labor. You don't have to be in an advanced hospital for us to do AMSTEL. So allow me to move on. We will have discussions. If you have any other questions or comments, just note them down. We'll be able to get other sessions where we can interact. So importantly, we said that uterotonic administration was the single most important component of AMSTEL. Not that the others are not important, but this is the most important component. So it is always important to prepare the uterotonic so that as soon as the baby is born and we need to administer, we are not scattering to look for the cold box and where are the syringes and needles. Let's have everything prepared so that we are able to administer within 1 minute. Then we always need to remember to confirm for another baby before we administer a uterotonic and to give that uterotonic within 1 minute. And then importantly, we have mentioned we can use oxytocin, 10 international units, and this can be IM or IV. We can use heat stable carbetocin, 100 micrograms, which is normally 1 ml. For those who have seen it, I think we'll get an opportunity to look at samples. And this can also be IM or IV. Notably, when administering the IV for both oxytocin and heat stable carbetocin, it is slow administration, unlike when we are administering IM. And then the other alternative is misoprostol. In circumstances or in environments where you do not have oxytocin and heat stable carbetocin, then it is important that we are able to use misoprostol. And this can be sublingual or parectal, depending on the woman's preferences. So this is what we have talked about, the uterotonics that can be used for prevention. So we have uterotonics that we use for prevention, and we have those that, in addition to prevention, can also be used for treatment of PPH. So I'll not talk a lot about treatment of PPH. We have another team that will talk about PPH management. Importantly to note is that we can use oxytocin and carbetocin for prevention of PPH. as those are oxytocin receptor agonists. We have EGOT alkaloids like methagyne and igometrin. And then we have prostaglandins, carboprost and misoprostols. And we can also use combinations. Then for management of PPH, we have other drugs in addition, like tranexamic acid, that are used for management. Notably, tranexamic is not used for prevention. It is used for management of PPH, but we will look at that when when we have the team that is discussing emotive. So another important aspect to note is that we need to be able to examine the placenta well. Because of time, I will not play the video right now on examination of the placenta, but it is something that we'll be able to share. But we need to examine the placenta well before we discharge a woman from that bed. Sawa sawa. So that we are able to pick if we have any retained products of conception, and we will see the causes of PPH. When we come to the causes of PPH, if we have retained products of conception, they are part of the reasons why we could have PPH. So we will share this so that you're able to examine the placenta well, beginning with the cord, to the placenta itself, to the membranes, all those aspects of the placenta. And in addition to preventing PPH, examination of the placenta would also tell us additional things about the baby or the pregnancy or the woman. If there was a short cord, it could help us understand if there was maybe a prolonged labor. If we had a cord around the neck, we could learn a number of things from the examination of the placenta. But importantly, it would help us know if we have membranes or the placenta retained. So then why is PPH still a problem? We know about active management of the third stage of labor, but we still have PPH. Or have we stopped having women with PPH? We still have women with PPH. Among us in the room, a number of us during our labor experiences underwent PPH. So many women who experience PPH have no identifiable risk factors. What are we saying? Anybody can get postpartum hemorrhage. Any pregnancy can result in postpartum hemorrhage. A woman who has all the factors normal, high HB level, is stable, no infections, is doing very well, the labor has progressed well, that woman can go into postpartum hemorrhage. So we do not have very clear identifiable risk factors. And therefore we are saying any pregnancy is at risk of PPH. So we have delays in detecting PPH. Many women do not present with symptoms initially. And by the time a woman presents with symptoms, most of the time a woman will tell you they are dizzy, right? Or you see they are almost falling down. By the time a woman gets to dizziness due to PPH, then they have significantly lost a lot of blood, and we have lost time during which you could have acted to manage the PPH. So when we have delayed or inconsistent use of interventions for PPH management, then we see the complications coming in. The other problem is we still have poor blood loss estimation. How many of us passed by this table? Show of hands. I think those who came in later did not get an opportunity, but we will now get feedback. We'll get feedback on that table. So blood estimation is also a problem. We estimate blood using our eyes. This looks like how many mLs? Most of the births that are, they are normal, no complications, are how many mLs blood loss? 100 and 150. If we go back to the files, almost every blood loss is indicated as 150 mLs. That is what we see. So we do not do proper blood estimation. We cannot have accurate, but we need to be able to estimate objectively. So that is another problem, and that is one of the other reasons why PPH is still a problem. And then even when we have national guidelines, many healthcare providers do not follow the national PPH guidelines or protocol. It could be that they do not know what should be done, or they already know but they just do not follow or are not in a position to follow. So then what are we reminding ourselves? That PPH is critical. And the most important thing to prevent PPH is active management of the third stage of labor. Sawa sawa. Tuko pamoja. All right, so I think I would like to take this back to our moderator to invite the next presenters to take us through blood loss estimation. And as she comes, one other thing that we would note about the video that we saw, that we will now learn differently this afternoon, is use of calibrated drapes. You see, for many of our facilities, we will just estimate, as we say, using the eyes. We do not know at what point we can collect that blood and estimate it. So by the time we remember to look at the blood loss, it is all over the bed sheets, it is flown down to our legs. So I think that is part of the other things that we will learn this afternoon. Are we together? Are we feeling slightly more confident in Amstel and the components of Amstel? Sawa sawa. So thank you very much. Back to you.
Thank you so much. A round of applause for our beautiful, soft-spoken doctor. Thank you. That with the Amstel, if you apply it well, we reduce cases of PPH by how many percentage? Hello, team. 60. Thank you. And we realize that for us to reduce maternal mortalities due to PPH, we need evidence-based and effective interventions to help us reduce these cases. And that's why WHO came up with something called Emotive. And the team that is coming next are going to take us through Emotive. Remember, if you allow a mother die in your hand out of something that is preventable, that is human right what? Violation. Are we together in that? So just count the number of mortalities that have happened in your hand. Those lives that you have lost out of something that is preventable. You have violated their rights. So, as the team comes in, I wish to invite Caro. Caro, yes, from Muranga. There is this boy that comes from, this place is called what? Bamburi. Tuko Bamburi wapi? Karibu niseme mtu hapa. All those names. Amalikoni, wapi. So there is this boy who comes from Bamburi. And Caro wants to tell us something about this boy. So please, let us all rise up and join Caro in taking us through this boy. There's a story of this young boy.
Thank you, Helen. Good morning. Good morning, colleagues. Hello. Hi, cousins. I'm Caroline Macharia, a midwife from Muranga County. Muranga County is where we have our governor, His Excellency, Dr. Irungu Kang'ata. Munamjua? Yes, and proud to be associated with him and working in Muranga. Sawa sawa. So there's this young man we are in Bamburi. Bamburi has 3 syllables. So it goes that the young man came to town with everything that belonged to him. So it goes, The young man of Bamburi has just come to town, and the young man of Bamburi has just come to town. You repeat after me. And you sing with energy. Sawa?
And we want to get the soprano, the altos, the basses, and the tenors.
Sawa, sawa. The young man of Bamburi has just come to town, and the young man of Bamburi has just come to town. The wife of the young man of Bamburi has just come to town, and the wife of the young man of Bamburi has just come to town. Of the young man of Bamburi has just come to town. The son of the wife of the young man of Bamburi has just come to town, and the son of the wife of the young man of Bamburi has just come to town. The dog of the son of the wife of the young man of Bamburi has just come to town. And the dog of the son of the wife of the young man of Bamburi has just come to town. The tail of the dog of the son of the wife of the young man of Jamburi has just come to town. And the tail of the dog of the son of the wife of the young man of Bamburi has just come to town. And the tail of the dog of the son of the wife of the young man of Bamburi has just come to town. Now, for the last one, you have to capture 7 items, eh? And I can see some people are just clapping, not singing. So for this, make sure you capture 7 items, eh? All the way from the flea, the fur, the tail, the dog, the son, the wife, and the young man. Ni sawa? That is like a small Mwa Kenya. Sawa, twende kazi? Let's go. The flea of the fur, of the tail, of the dog, of the son, of the wife, of the young man of has just come to town. And the flea of the fur, of the tail, of the dog, of the man of Bamburi has just come to town. Hi, asante sana. Back to the chair.
Hi,
asante.
Thank you so much. A lady from Muranga. So how many people got it right? Please come. This is a challenge. Come, please. Yeah, come. Just come. There's a present for you. You got it right? Yeah, please come. Let us appreciate her. She comes forward. Thank you. Karibu. Karibu sana. Let us start with the what and the what and the what. Okay.
Hello everyone. Akisi mtanisaidia. Tumesema ni flea, fur, tail, good. Let's go. Let's start. The flea of the dog. Okay. Let's start. Together we start. The flea of the fur, of the tail, of the dog, of the son, of the side of the fur, of the tail, of the dog, of the son, of the man of Bamburi has just come to town.
A round of applause for her. Thank you so much. And so, let me bring in our young Gen Z. Yes, our young people, our ministers, to take us through this thing called emotive. I think everybody participated there, and the result is quite amazing. Karibu sana, our sister and our brother. Karibuni.
So, hi everyone, how are you? Are you excited to go to the next phase? So, we did an activity as we were doing the registration. How was it? Did all of us complete this chart? So how was the exercise, the machometer? The machometer. So, are we ready to receive the results? So that we can see nani amepata yote? So, the first station, station A, there was a clothing of a woman who just gave birth. Everything is soaked in blood. You've removed all the lasers. And the woman had lost 600 ml of blood. 600 mils of blood. Polycarp, someone has it right?
So A, we had 1,000 here. We have 300, 200, 500 mils, and 100. I think 100 is the lowest here, and then 200. So the lowest is 100. The highest is actually 1,500 mils. Yes. And the blood loss is 600.
So we proceed to B. Someone got it right. I have a sweet.
So there's 600 here. One. There's someone, I think we only had we only had one person. No, two. Two people got it right. 600.
Okay. A clap for them.
600.
So I owe you a sweet. So we proceed to B. The woman had lost 300 ml of fresh blood. Station B. Polycarp?
So B was 300. We have 300 here. The 500 mils, 1,000, 1 liter, 600, 150, 500, 300, 700. So the lowest here we have 100 with the highest being 1,000 mils. For the 300 we have, most people are between 250 to 350 in terms of estimation. So that is part B.
So
But because I can only see one, actually there are around 5 who got it right.
A clap for them. So we move again to C. There was some fresh blood with a soaked gauze. Some of you were able to appreciate the gauze, others were not. So the woman had actually lost 100 ml of blood.
So for C here, we have a lot of hundreds. It seems most people, the lowest being 50. The highest here being...
there is a 25 Polycarp.
Oh, yes, 25. Yes, 25, 80, 50. The highest being 400 mils, but a lot were between 50 to 100 mils. So we have a lot of hundreds here.
A clap for them. At least... has anyone got something right so far? Okay, we proceed to D. There were 500 mils of clotted blood at station D.
So for the blood clots, here we have 1,500, 2,000, 400, 650, 1,500, 400. The lowest here being around 200 mils, the highest being 2 liters of clots. Here we're talking about clots. So you can see several people with also several 400 and 500 here.
Okay, thank you for that. Who got it right? A clap for them. So based on the exercise that we've done, I would like to get your feedback. What do you feel about this exercise? We can have 2 people responding about the machometer. What do you feel?
What do you feel about visual estimation of blood?
Philomena Munga is my name, from Kilifi County. The estimation can lead to either overestimation of the blood loss or underestimation of blood loss in most of the time.
Thank you. One more person.
Any person with different? Yes, yes.
Thank you. I'm observing from a communication point of view. I think the visualization may lead to delayed response or the intervention, because you may underestimate and then you may overlook as it as not a serious matter. But if you do it the right way, then you can easily give an intervention. But if it's just through visualization, it will lead to delayed response to complication.
Okay, thank you so much for that. So can we all agree that the visual estimation of blood loss is inaccurate? Because everybody will use their eyes to see whatever they want to see, and we're not judging them because that is what they felt was the blood loss, right? But if we could have something objective to help us determine how much blood has the woman lost, we are going to be at a standard point when we do objective measurement of blood loss. And that is where we have the calibrated drip. Because as you can see from the exercise, for the first one we had as low as 100, and we had the actual was 600. So if I can see 100 and you can see 600, that is, you are able to see the actual is 6 times more than what I saw, right? So what will happen by the time I'm able to see 1,000? How much has this woman lost? She's lost a lot of blood, right? Yeah, so an objective measurement tool for blood loss has been recommended by the WHO so that all of us are able to manage the woman following same practices. And that is where the concept of the calibrated drip comes in. So we have various ways of objective measurement of blood loss. And some of them include the Kelly's pad with a basin. We have a standardized cloth with a mat. And we have the calibrated drip. So a calibrated drip is just one of the ways that we can use to objectively measure how much has a woman lost. So we need to note that maternal death from PPH can be prevented whenever we use locally available evidence-based and effective interventions. And we need to utilize comprehensive strategies to reduce maternal deaths, because having a woman die from something that is preventable is a violation of their rights. So it is from this recognition that the WHO came up with the emotive approach to the early detection and also the treatment for PPH. So what is a clinical bundle? A clinical bundle is a small set of interventions which are evidence-based, and whenever applied to a specific population of people, we can have significantly better outcomes compared to when the interventions are done alone. So the bundling of care is done so as to improve the quality of care and also enhance efficiency. So bundling emphasizes not only the clinical activities, but also teamwork, communication, and cooperation, as we have seen from the previous presentations. So the emotive bundle is an acronym for early detection of PPH. The M is massage, oxytocin, T for oxytoxic drugs, T for tranexamic acid. We have the IV fluids, then examination and escalation. So in this bundled approach to care, it's recommended that all the interventions are given together rather than waiting or giving them sequentially. So that is the emotive approach. Previously, these are things that we do in our clinical area. Or is there anyone who is seeing something new? In terms of massage, do we do that? Oxytocin drugs, do we give? Tranexamic acid, do we? And also other treatments. Then examination, we still examine our clients. But now in the bundled approach to care, we are giving all the interventions together within 15 minutes, rather than watch and see. You could have a woman who is bleeding and then I tell you, I can see, huyu mama ana bleed, tufanye nini? Tunasema, ai, wacha tu massage kidogo tuone kama uterus will be okay, right? Then we massage, go back to the cardex and write we've massaged. 10 minutes later, I can see there is still some blood. Can we give oxytocin? We fix, let us fix, we fix. 10 minutes later, oxytocin is over and you can see there is still a trickle of blood. Now you want to change your decision. Can we give tranexamic? Or do we call the doctor? What do you think we do? Now we do something else. So the bundled approach, rather than doing everything in a sequential way, we just give all the interventions within 15 minutes. If they do not work, then we move to the next thing. And the good thing is, when we give the bundle, more than 80% of the women will respond and bleeding will be controlled. And now we are able to move to do other things, rather than watching, waiting, which is consuming a lot of time. It's delaying the quality of care and also worsening the prognosis for the clients. So just what we've said, comparing the sequential approach, you see how long it is. It's a long time that we are consuming as we wait for the woman to, as we wait to see what is happening to the woman. But when we use the emotive bundle approach, we are able to shorten the interventions within a very short time. And as we shorten the intervention time, we are also shortening the time that the woman is bleeding. So there is the component of rapid escalation with the emotive, which is not evident in the sequential care, which is taking a lot of time. The emotive bundle, as we mentioned, is done within 15 minutes, and we have an objective tool for measuring blood loss, which is the calibrated drip. So, Polycarp. So we are going to briefly see how is the calibrated drip. There are so many versions in the market. We have this version which is one use and disposed. We have another one whereby you can reuse the mat. So you can show us the mat. So we have a mat that goes to the back of the woman. Sorry. So the mat goes to the woman's back. We have straps on the side to secure the drape onto the woman's abdomen. You make sure it's tight enough to prevent spillage of blood, but also loose enough not to be uncomfortable. Then we have the lower portion, which is the pouch. It is calibrated so that you are able to read how much has the woman lost. So there are calibrations down there. We are going to pass the drips around for us to see later. So we have a yellow warning line whereby it alerts you, like, I think this woman could be bleeding, and then you know, let me watch out. We also have a red trigger line whereby now you can see this woman has reached 500 ml of blood and I need to treat as PPH. That is just in case I hadn't begun to treat. So we use the drip for vaginal births and not for cesarean sections. And we apply the drip as we anticipate second stage. So we apply on the woman's back, then we tie and secure. But then we are folding up the pouch to allow for the birth to occur. So Polycarp is showing us as we continue. So remember, we want to estimate all the blood that the woman is losing. We do not want to have liquor in the drape. We do not want to have any urine, no fecal matter on the drape. So that is how we secure the straps on the woman's back. Are you able to see? I think yeah. So once secure, our baby is not yet born, we roll up the pouch over the woman's back. Remember, we are not collecting blood at this point.
Before you conduct a delivery as a midwife, you ensure that when the woman gets into labor, you place the drape and then you just secure it, not too tight, comfortably, but then you fold it. The reason why we are folding it is before the baby comes out, we normally have other things. Yes? So when they enter into the pouch, they'll interfere with the readings. We only need to collect blood on the drapes. So after the baby has been delivered, after the second stage, we are saying after the birth of the baby, before delivery of the placenta. So when the baby comes out, before you deliver the placenta, that is when now you open, or rather you unroll the drape, so that when the placenta comes out, that is when now bleeding begins at that point. Yes.
Okay, thank you, Polycarp. So baby out, we give you trotonic, we start measuring blood loss. So if the placenta, as we birth the placenta, if there is any clot within the membranes, we drop it into the drip. Remember, only blood goes into the drip. Any fully soaked gauzes, which must be lightweight, not the gauze rolls. So we use the lightweight gauzes, and they have to be fully soaked. If it's not fully soaked, we don't put it in the drip. Urine doesn't go into the drip, no cotton wool, and no pads. And as we are monitoring the woman on the drip, she is not wearing a pad because we want all the blood to go in there. As you come to examine the woman, you will massage the uterus as we always do. Check how is the vaginal blood flow. Sweep all the cloths into the drip, and then you read, and not the other way around. You don't read and then go back to sweep more cloths. So as you can see, we massage, check how is the flow. The woman is actively bleeding. Sweep all the blood, because under the buttocks some blood could accumulate there. We sweep all of it into the drip. And then once we sweep, we are going to read and know how much blood has the woman lost. So I think we can have like 2 people read.
Can I have 2 volunteers?
And Polycarp will first show us how we are going to read it at the eye level.
So I've held it that way so that the bleeding comes. Yes. So for the facilities that have, the modern maternity beds, you'll realize the blood will definitely flow via gravity, but we have those that still have the flat beds in our labor ward. So for the flat beds, you can, like she has said, you can just sweep the blood to come in. So for the reading, it must be at the eye level. So do not fear, because we bend a lot in the labor wards. So this should not be a difficult one. So you have to bend, and then raise it comfortably to your eye level, and ensure that it is straight so that you can get the correct reading. So I'll want to get maybe, so as you also read, avoid touching here because basically you'll interfere with the reading, or don't hold it with one hand, or do not read it like this. You will not get the correct reading. It has to be suspended and at your eye level so that you can get the right reading for that. So I'll get maybe one or two people to come and tell us the reading for this for this blood.
You just come and read. Okay, thank you. We can have someone else accompany her. Thank you. Okay. How much blood has the woman lost? Remember, you are alone at work. Yes, you're alone. 4:45. Okay. Around 4:40. So one says it's 4:45, the other one says it's a 4:40. Polycarp, what's the actual for you?
It's 4:50.
4:50. We have a 4:50, we have a 4:40, we have a 4:45. How is the difference? Negligible, right? So is this woman going to receive the same care from all of us? If we were attending to this woman, one says it's a 4:40, then a 4:45, then a 450 ml. Compared to when we have one person saying it's 100 and another saying it's 600 or even 1,000. So in which scenario are we going to give standard care? The one where we are using an objective method of determining how much blood the woman has lost. So the drapes are available at KEMSA and also meds. And as I was saying, we have one where it's entirely disposable. We have another one where the mat is recyclable for up to 100 times. So you just need to purchase the pouch. And we also have a biodegradable version. So we are moving forward. So while using the drape, we want to know how are we going to diagnose PPH. And we call this the triggers for the motive bundle. So how do I know when now it's time to administer the emotive bundle? So the first criteria that you can use is when the woman has lost 300 ml on the calibrated drape and we have a warning sign. A warning sign could be the uterus is not yet contracted. Could be we still have a lot of blood pervaginally flowing out. It could also be that the woman has a systolic BP is going down, that is below 100, or a change of 20 from the baseline. Then another warning sign is when there is tachycardia, that is 100 beats per minute for the pulse, or an increase of 20 from the baseline. So as we determine this criteria, we need to remember the baseline such that we need to have we need to know what was the baseline. How did this woman present to us? And then we are able to determine now, I can see it's tachycardia. Now I can see this, there is hypotension, the systolic BP is going down. So we need to have a baseline so that we are able to compare when the woman is bleeding. Is it a routine practice to do vital signs when the woman is admitted? Amani, sometimes. It's a routine practice. That is a good practice because someone with a systolic of 140 cannot compare to someone with a baseline of 105 or 110. because as they drop to 100, the drop would be significant for the person who had a higher systolic BP. So the first criteria is when there is already 300 ml of blood and there is a warning sign showing if this woman continues to bleed, then we are going to have poor outcomes. The second criteria on when to trigger the emotive bundle is when the woman has lost 500 ml of blood, regardless of all the other factors. So you check the drape is 500, whether the woman is bleeding or not. Because we've reached the classical definition for PPH, we start the treatment immediately. And then the third criteria is a clinical judgment, and this should take precedence over the rest of the criteria. It's you who's been caring for this woman. You feel that she might bleed, and maybe she's even lost just 100. And you feel like, I don't want this woman to bleed, or she's bleeding, she might continue. So you administer the emotive bundle. At any point when you feel this woman needs additional treatment. So clinical judgment takes precedence. Maybe you've been caring for a woman, she's anemic, she had a HB of 8. Would you like her to bleed even the 300? So you might want to just treat her. You had a woman with preeclampsia or eclampsia, she's been fitting all night. Do you want to handle PPH? So the clinical judgment is your own assessment, your own monitoring of a client. Maybe she's had a multiple pregnancy and you feel this woman is at risk of atony. You judge and then you intervene accordingly. So the drape is just a safety net, just to make sure we are safe if at all we hadn't taken action. But clinical judgment takes precedence over every other thing. So as we mentioned before, the E in the emotive is for early detection. And then I will ask, have you ever had a woman, she's given birth, and then you clear her, the delivery was very clean. Isn't that what we call it? Very clean delivery, no tear, no nothing. 15 minutes, everything is done. We are taking her where? To the observation room. So the woman stays, and then she stays. Like 1 hour later, it's time to go where? To the postnatal ward. So, hi mama, come we go to the postnatal ward. And then what happens? The woman is just falling on you, or there is a huge gush, blood is spilling everywhere. So the emphasis is on the early detection. So rather than waiting for her to bleed, there is a lot of emphasis in monitoring this woman quarter-hourly to see how is she doing, rather than coming after the 2 hours and then we are managing a crisis that will involve everyone in the facility. So using the calibrated drape, we are able to monitor how this woman is progressing over time and intervene accordingly. So with early detection, we are going to be able to have less blood loss. We are going to have timely treatment using the locally available resources from the motive bundle that we are going to see. We are going to reduce the rates of blood transfusion. We are going to reduce ICU admissions, those laparotomies, and we are going to have a healthier woman who is able to care for their own babies. So at this point, I would like to welcome Polycarp to take us through the next phase, which is the motive bundle.
Hello. Are we still together? Let's appreciate her as she, for the good work. Let's clap for her. Thank you. So I'll go very fast because of time, and because much of this we are not new in this field and we've had them, but I'll pick out the very important points so that we may take them home. So we are saying the WHO recommended emotive bundle should be administered, the whole bundle, within how many minutes? Within 15 minutes. Coming out from the sequential that you would give one treatment, you observe, you wait, by the time you are giving the full range of the bundle, the woman has already reached severe PPH and probably into shock. So there are two things. One of them is the calibrated drip. And right now, because this is plastic, we have innovations in the country to address this. One of the innovations is to come up with a reusable drape or a biodegradable drape. So we have a reusable drape that is already in the country. It comes with about 5 pouches. So you can use them for 5 clients with one. So the top part that we've secured on the mother, you can disinfect according to the protocols. And if time will allow, we shall share how that protocol looks like. So the second acronym from the E-motive, we've done the early detection, is massage of the uterus. And massaging of the uterus is something that I think different people have got different ways they do the massage. And we are saying one of the things we should think about is that when you are doing the massage of the uterus, already we've shouted for help. You are not managing this woman alone. In the event, now in the ideal situation, you're in that dispensary, it is at night, you are alone, you are conducting this delivery, and this mother is going through PPH. What happens? We are saying you need to involve this mother in some of these activities. You need to teach her how to massage the uterus as you provide the other interventions. Many a times, we do a lot of things without the mother. You know, the mother is even wondering what is happening because everyone is running around. Nobody is telling her what is happening. But we need to involve them. And that one we've learned from the SBA. It may hurt because the uterus has not contracted. We need to teach, like I've said, and work together with the woman. And I will ask a question. How does a uterus that is soft feels like? Do we know how to differentiate a soft and a uterus that is well contracted? That is hard. During the practicals we shall do, we shall check both for the hard and for the soft uterus. But then, that is a practice that we need to do today. So before you leave, you must know when do you say that this uterus has fully contracted. And you need to check the tone at least every 15 minutes for the massaging. So the massage is something that is continuous, involve the mother, involve your assistant who is there. On the oxytocic drugs that we are giving, here we are now in the treatment of postpartum hemorrhage. We've diagnosed. Are you seeing any element of heat-stable carbetocin here? Do we give HSC at this point in the treatment of PPH? Why don't we give heat-stable carbetocin? Yes? Why? Why do you think it's bad to give HSC at this point? You can try.
I think it's because it's preventive. It's not for control, for not treatment of PPH.
It has not been recommended for treatment of PPH. Any other person? Why are we not giving heat-stable carbetocin at this stage? Any trial? What happens? What is the mode of action of HSC? How does it act at this point? In the event you give heat-stable carbetocin here mistakenly, what do you think will happen to the mother? Yes? Yes, go ahead.
One, at this stage we cannot give heat-stable carbetocin because we might have given as prevention and we don't repeat a dose of heat-stable carbetocin. Then the mode is it works on the receptors.
Thank you so much. So I'll take those two answers. One, it has not been recommended for use in the treatment of postpartum hemorrhage. I know there are trials currently happening for use of HSC, but it has not yet been recommended. The second aspect, both HSC and oxytocin, they still bind to the same receptors. But we look at the mode of action, the way, it has sustained contractions. Up to how many hours? Yes? How many minutes for each stable carbetocin? 120? Yes. So you can imagine, we also give carbetocin at this stage, how that will look like. The other bit, the oxytocin that comes here, it's a treatment oxytocin. That means we are giving it IV. Okay? So what do? We are saying oxytocin is given 10 to 40 IU in 500 to 1 liter ml of normal saline. But the first thing that we do is that we give first oxytocin 10 IU in 500 ml to run rapidly, as fast as possible, over 10 minutes or around 10 minutes. That means when a woman presents in labor, the first thing we should do is that, what is the first procedure? The woman must have an IV line. That is a standard. We said PPH cannot be predicted. So you must have, and if you put cannulas during delivery, that's not a good practice, because the veins may collapse when you've not done anything else. So after the loading dose of the oxytocin has gone, then now we give the 20 IU in 1 liter to run over 4 hours. That is the maintenance dose. So in total, how many doses of oxytocin has this mother received from admission to this point? How many? These are how many? 30 plus the one we gave for prevention. So 40. In PPH, let me take this now. And I know we are guilty. You might find midwives who have given over 60. It's true. 60. Am I lying? There are those who've given over 40. In fact, they say that contraction is still weak. Let us pump in more oxytocin. So now this is the practice. And in the aspect, we also have misoprostol coming in. And we are saying, do we give it parectal or we give it sublingual in PPH? Yes? Have we administered miso? How do we give it in labor? Yes? Do we give it parectal? Somebody? Yes? Do we give it parectal or sublingual?
Parectal.
Why parectal? And every answer is correct. We are saying every answer here is correct. It depends on how you qualify it. Why parectal?
I don't know.
Parectal.
If the client is unconscious, you give parectal. Someone else, why not sublingual?
Every answer is right.
So if the client is unconscious, there is no mechanism of opening the mouth?
I want to look at labor and delivery.
Yes.
And the presence of contractions that are increasing in intensity and frequency. And how the mother can sustain that misoprostol sublingually. It may be a little bit difficult. So it is safer rectal so that we can have maximum.
So they are saying it's safer rectal so that the mode of action becomes very rapid and then it's sustained. That's what you mean. Those of us who are sublingual, hey, I'm alone in sublingual. Yes, qualify the sublingual. And you can see the practices we have in our labor wards. Yes, go ahead.
Okay. I prefer giving it sublingual because I've done it in experience and I find it working very good.
Thank you. So that is out of experience. It is working very good. Any other person sublingual? Then we continue. Yes, go ahead.
Okay, I'm Felix.
Yes, Felix.
Both works, both sublingual and parectal, but sublingual is more rapid. It's more effective than parectal, which is sometimes unpredictable. Yes.
Okay, thank you. Is there someone who has a burning response between PR and SL? So we are saying this woman still has contractions. What are the chances if you give it parectal that that drug may come out? What are the chances? Yes? There are high chances because we are actually expelling things. So there are high chances. However, we are saying in the aspect, because we have seen here also there is experience. In the aspect you feel it works well. But what we recommend here is you give it sublingual, if possible, because parectal, you may not know. You know that time you're also examining. You are doing your own things. So discharging that drug becomes very fast. But it's a good discussion. We can have it in the parking lot to see how it goes. I can see there are those who still want to contribute. Allow me to proceed. I will give you time for that. Then we come to this drug. It is called TXA or tranexamic acid. And I'll ask, what is the class of TXA? It's an anti. It's a what? Anti-what? I said all answers are correct. I'm just here getting, it should be, yes? It's in which class? Just try.
Antifibrinolytics.
Thank you so much. So what do they do specifically? What is their role? Even in a layman's term, what is the role of this class?
Someone?
Yeah, there's a hand there. Where? We're actually winding up. Yes. So in the next.
It is just a hemostatic agent.
So what does it do?
It helps in clotting.
Exactly. Thank you so much. So we are saying TXA in the emotive, you give it comes in 1 gram. There were some samples here for those who would like to see. You'll get to practice with it there. So it is given for over 10 minutes. Okay? So you give it, that means how many mils per minute? So the beauty about TXA is that once you insert the syringe and you are alone or you don't have manpower, you can be pushing it while you do the other. You provide the other bundles and you come and push it for around 10 minutes. And then we also TXA acid we need to have for facilities that still do not have protocols for this. I don't know how your facilities look like. If you are allowed to access this medicine, then you need to initiate that so that it works for you. So we assume that the site where if this is our placenta, so when the placenta detaches from the uterus, it leaves a big wound like this. Sindio? So we are saying the work of this drug is to come and provide the clotting issue so that that wound stops to bleed when it detaches from the uterus. So it's a very important drug, and we shall learn more about it during the practice sessions. Then we have the IV from the emotive. The IV is basically on IV infusion, and we've talked about it. And why are we giving, I'll just ask a question. Why normal saline and not Ringer's lactate? Or can you also use Ringer's lactate here? Maybe that will be easier. After that, we are through with this class. Why are we saying we are giving this crystalloids? So Ringer's lactate is in which class of fluids? Yes? Do you want to answer? Just go ahead.
We give crystalloids and not colloids because of for like plasma expanders, like
create plasma expanders, and what else? Oh, we give you time to, you need someone to support you. We have, yes, go ahead, go ahead. There's a hand somewhere there. We start here.
Okay, because this is a mother who is losing volumes, we want something that will remain intravascular so that we can have the plasma expand and support this mother.
Thank you so much. Yes, go ahead.
I think when you are anticipating transfusion, you have to restrict ringers lactate. It might lead to clotting.
Why are people looking shocked? Like you've brought new knowledge. So that is the reason. But in the aspect of, I want to ask now within our ideal setting, in the aspect that the only fluid that you have between you and that mother is ringers, what happens? Will you send somebody to the pharmacy? That is from your practice. You want to get, what is our practice? Do we always have normal saline 24/7? Do we have normal saline in the maternity 24/7? Okay. There are a lot of no's, then there are yes here. So we'll also learn this when we'll be doing the practice session. There's a lot of practice to do, and we'll explain why. But like they've said, whatever answers they've given is very much correct and in order. But we must also be alive to the environment we are working in. So that these women. So I think I'll close my part here on examination. So the E motive is either, the last E is either to examine or escalate. Please do not die with that mother alone while you can escalate the situation. And escalation means you can get a second opinion from your fellow midwife. You can call a doctor. You can call the call room and all that, so that people can come in and give you insights. Escalation also means referral at this stage. We lose women because the referring facility took a lot of time to make a decision to refer this woman. By the time you reach here, the woman is still bleeding. You've given the whole bundle for treatment. And you've examined, and you've now gotten the course. If that course cannot be handled at your level, the beauty or the better part is that you need to refer, escalate that issue as fast as possible. The challenge we are having, people in the maternity, we start, the midwives, we always start by examining first. Then that's when you come to the bundle. But here we are saying, once you've already diagnosed that it is PPH, don't even go to the examination bit. Give the emotive care bundle as it is. Then now come here and start examining this woman. And we are saying all these things will happen within 15 minutes. So we are time bound. So you check if the bladder is full for all women. We shall check Mama Natalie when we'll be seated there and see how does the bladder also interfere with uterine contraction. We also evacuate clots, and you also check for tears and examine these women. And then you also, at this point, you also check for the completeness of the placenta. We shall learn these skills. These are better done practically when we leave. So it is important that the last E, it's examination. And if you've already said, because there are 4 T's of PPH, we are saying it is torn, trauma, tissue, and thrombin. So if it is thrombin, for example, and you can't handle it in a level 2 facility, what do you do? If it is tears, maybe, which one? Vaginal, we have cervical, we have those ones. Do not start being a consultant at that facility. You don't have the resources to do that. Escalate that issue as much as possible. And I'm finishing by asking a question. Do we still pack the uterus or the perineum? How many still park here? So people are doing well. Okay, thank you so much. So we continue with this discussion in the afternoon. I'll take this back. Thank you.
Okay. Thank you so much, Polycarp and Joan. Let us give them a round of applause as he leaves. Guys, thank you so much. So remember, this is that mother who came to your facility walking alive and well, the baby playing so well, expecting to go back with the bundles of joy. The baby's room is prepared, either blue or what? Pink. The siblings are prepared. Budget is made. Everything is set. Relatives are told. Where I come from, even the mother-in-law is already there. And then, because of you and me, we end up reaching where we have reached. So we have really tried with emotive. We have reached there. And now we want to see, when all this fails, what next? So I'll take this opportunity to invite and to welcome our next presenter, that is Sarah. Let us clap for her until she comes. Until she comes. Until she comes. Until she comes. It's not harassment. Karibu sana. Thank you.
All right. Tunaweza simama kidogo. Kindly stretch. Yeah, just stretch. 2 minutes stretch. All right, we can sit now. We can sit. So we want to continue with where we have stopped. And now we want to do escalation. If all what you have done is not working, your patient is still bleeding, your mom is still bleeding, so you want to find out why she's still bleeding, even after doing all the measures that we've been told. We've been talking about 4 T's in PPH. And we know tone is the one that carries the day. It is the one that has a lot of mortality that we get in our facilities. So we need to actually find out why our patient is still not bleeding. And the very first thing that we want to do is to do the basics. So we are as midwives, we are going to be doing the basics. And the basics are the ones that at times are left out, and then our patient complicate. And want to examine very well, and then be able to catheterize our patient in case you get a uterine atony, or you're suspecting that your uterus has not, your placenta has not been delivered, and so you will want to remove it manually, very important. And then once, remember we started with active management of that stage of labor, that we were told in the morning, if it's done very well, prevents 60% of our patients will not get into PPH. That was the statistic that we got. So when you're doing Amstel and you do it very well, then you're able to avert PPH by that percentage. Then the patient is still bleeding. Then we need to find out, do we have tears? Do we have a retained placenta? Do we have a throbbing issue? Or what is it that is disturbing our mothers? So once we will talk about a retained placenta, and you'll be able to discuss when we say that our placenta is retained. So we are talking about a patient that has just delivered. You're continuing with the management. Remember, this is active management of that stage of labor. So you continue with the management of that stage of labor. But within your 15 minutes, at times the third stage doesn't even get to that 15 minutes. It's even shorter, isn't it? Yes, through practice. So you are yet at 15 minutes and you're not yet delivered your placenta. So try to go back and find out whether the patient has a full bladder. So do the basics. Of course, do the basics. And then from there, if you are not actually stopping at standing there and waiting for 15 minutes, you're doing some interventions. So emptying the bladder, communicating to your patient, and then when you get that your placenta is not delivered by 30 minutes, then you try to plan for manual removal of placenta. Remember, we have what we call Pacreta symptoms or syndromes, where you have placenta pracreta, increta, and all that. So also be careful that you do not force your placenta to come out, and you've not ruled out the other causes that would have caused your placenta not to come out. We will do that practically in the breakout session, so we'll teach you on how to do that. So after 30 minutes of your placenta retention, it is time for you to remove it manually. Okay, and we'll do that in the breakout section. And then even if it's not a placenta that is retained fully, the entire placenta, then you are able to examine and find some fragments that may be missing and ensure that you remove them. So we'll teach you how to evaluate a placenta and how to note which fragment is missing. So it's short as that. So we'll start with that as part of escalation. And I want us to play a short video to that. Then I continue. So that we don't waste time, as we bring another laptop that has internet, allow me to continue. We will watch that later. So allow me to continue with the slides. I'll go back there. Good. So we have done manual removal of placenta. Patient is still bleeding. So we want to assess for uterine atony. Patient is still bleeding. Retained placenta, we've done that. Lacerations, we have sutured. Remember, in escalation, we handle the cause. So if there are tears, we repair them. Cervical tears, we are teaching midwives on how to repair tears. We've done that in the national EMOC trainings. And it is important because what is important for cervical tear repair is just identification. If you're able to assess the clock where the tear is coming from, then we teach you how to make a suture and be able to arrest the bleeding. So we can do that as midwives. And so whatever laceration, the only thing that we'll not do a third and a fourth degree tears, remember? They have a lot of anatomy. They need a lot of visualization in theater and a lot of pain relief. So we'll need, that will be done in theater. So when you, this is what we are talking about, escalation. Mother is still bleeding. And the causes have been identified and management, but still your patient is bleeding. Number 2 is when the bleeding is, the causes are clear, but you're not able to manage. Like if you have an atonic uterus, the patient is on your table at cesarean section. You have an atonic uterus. So you need to do other escalation measures like a Billinch, a UBT, and all that. Then again, you also escalate when the mother is still bleeding, and you do not even know the cause of the bleeding. So that is what we are talking about. And I want to talk about what you do anytime in obstetrics or in our midwifery practice. When you get anything that is an obstetric emergency, the very important thing that you do is to shout for help, because because you'll not be able to do that alone. Shout, and you shout in terms of the condition that you're handling. If it is PPH, you shout and say, PPH, help, PPH, very important. And remember, we were taught in the morning about the drugs that you use for the management of PPH. And in management of PPH, we do not use heat stable carbetocin. That was clear in the morning. Heat stable carbetocin, we are using it as a preventive measure. There's a research that is ongoing in my facility that is trying to test whether it can be used as treatment. But as we know now, it is for prevention. Very good. It is for prevention. Then the other thing is, Kenya at 1, 2, 3. So the other thing, once you call for help, then you'll be able to find out the management that you continue. We were taught about the oxytocin that you give, the misoprostol, the tranexamic acid. That was clear in the morning. I don't want to dwell much on that. And then consider interventions for refractory PPH. Refractory PPH basically means the PPH that has not cleared with the management that you have done initially, and now you need other combined management for you to handle the patient. And what we do is, so what you are supposed to do is in whatever order. We are not going to tell you that you'll start with UBT, or you're going to start with NASG, or you're going to start with aortic or bimanual compression. It's whatever can save your mother. At that particular time, which skill are you able to rush for within the next PPH kills very fast. So within 15 minutes, you'll have known which method to start with very fast. So the escalated methods that we use, one is UBT. UBT basically means uterine balloon tamponade. We have of two types. We have a free flow. We will show you behind there. It is called free flow because you do not need to do any interventions. Once you put your fluid, how we are going to show you, you just leave it hang. The only thing that you'll be regulating is the height. The height, checking with the systolic blood pressure. We'll teach you in the breakout. So systolic blood pressure, that is what? Your pulse, the rule of 20. We'll be talking about that in the breakout session. So that is UBT. So you have two. One is the improvised one. The one that we know, we use a condom, the kawaida condom. So I always tell people, as a midwife, if your spouse gets you with a condom, naeza jitetea, it is for doing what? UBT in labor ward or in your walking around wherever you work. Yes. So just tell them that this one saves life, and I'm going to use it for that purpose. Okay? All right, so be wise. Be wise. So the other thing is that, so we have free flow, and the improvised one will teach you in the breakout sessions, and what actually you need to do. They have different ways of monitoring them, and once it achieves the purpose, then we have a way of now removing. We'll teach you in the breakout session very briefly. So number 2, you can do aortic compression. You compress the aorta as completely until you cut the blood supply to the uterus. That is the time that you will know that you have done it effectively. We'll show you in the breakout session. You can also do a bimanual compression. You insert your head to the anterior fornix. We'll teach you in the breakout session. It's clearer when it's done practically. The other thing is the more boda guys carry a gunia of viazi. You've seen them, eh? It's usually tied and squeezing the uterus together. We do not have a model of syringe, but in case you're interested, we can improvise something and demonstrate. So it just actually compresses. We call them compression sutures. So you just compress that uterus, and this is done for only atonic uterus. Whatever I am talking about is uterine atony. Do not apply a syringe where the cause of bleeding is a retained placenta. You're not doing anything, isn't it? Or a tear, cervical tear, a third, fourth degree tear. So for uterine atony is when you're going to do that. We can do revascularization for our senior consultants that they do. And then we want to spare this uterus as much as possible. And that is why we are trying to start with the less harmful. But in case you need, we have a lot of litigations, a lot of medical legal issues in removing a placenta, doing a TAH, in a patient that you'd have done other conservative management. So those are what we call escalation. And I have actually clearly talked about that. And the one thing that I have not told you is for nurse G, when you get your patient who is getting to hypotension, a patient who is getting into shock, we will demonstrate how to do a nurse G also. It is non-pneumatic and shock garment. How many of us have never, ever seen a nurse G? Then I reframe my question. How many of us have used a nurse G? Very good. Almost 100%. So I leave it there. So when we go to the breakout sessions, you will be the mentors for the others. So that the ones that are not able to do that can do that. It has saved life. There are success stories that have been written. So it is something that we can do. Good. We talked about that. And so once you're doing all this, ensure that you continuously monitor the vitals. The previous presenter talked about the earliest sign that you get when a patient, for you, that will trigger that the patient is getting into PPH is motive bundle. All right, so that basically, it's very good because this chart is standardized. So if you can have it in your facilities, you will have a more standardized way of handling PPH. So even the drugs, the last part is talking about the drugs that you've used. If you've done uterine, we can be talking, you can be asking a question, or you can do some input. You can do some input. But I can assure you, all what...
Give her a wonderful clap kindly. Tumpatie mingi. Thank you so much. We have really looked at a lot to do with prevention and now management. And I know when we'll go to the breakout sessions, we will be able to really now demonstrate a lot of what we have gone through here. So my name is Sylvia, as she has alluded earlier. I'm a PPH trainer, and I'm so passionate about women and the little babies. And just making sure that we save our women when they come to give birth in our facilities is something that keeps me strong and waking up to a better day, knowing that no woman will lose their life in my hands, because I'm empowered with knowledge and skills, and I'm able to share the same with my colleagues. So after you have done the motive bundle, you detected the PPH early, and you went through the motive bundle, what are you supposed to do to this woman under your care? And I was just remembering when we were looking at the estimation of blood loss, how we just miss out on detecting its the correct volume, because machometer inachoma, na ikisha choma, we end up complicating or even worse, losing the women. So after we have gone through the motive bundle, of course, we really need to monitor this woman closely for the very first 6 hours postpartum. Sawa sawa. So for the first 2 hours, we are expected to monitor this woman at least quarterly until she stabilizes. So for the first 2 hours, we are doing quarterly, that is every 15 minutes. And what are we monitoring for this woman? We are monitoring the vital signs. We are checking for the blood pressure, we are checking for the pulse, we are checking the blood loss. Of course, after you have managed the PPH, If the drape that you used is soiled, you can change her to another drape so that you are able still to collect the volume and you don't forget to total up whatever you had gotten in the beginning and now this new volume that will be getting from the new drape probably you have fixed. So this is a woman you are keeping a close eye on. You are checking her blood loss every 15 minutes for the first 2 hours. You are also checking for the tone of the uterus. Remember we have said tone is the leading cause of our PPH cases. And so a uterus that was earlier firm can turn to be soft. So it is important for you to ensure that that tone is maintained. And how do you do that? By ensuring the uterus is massaged. When you go to review the client, you massage to check whether it is firm, and you advise her to continue massaging every 15 minutes just to ensure that she feels that hard cricket ball-like thing in her lower abdomen. And then you also need to, we've said the tone, the blood loss, the pulse, and the blood pressure. And as you are picking them out, you need to record them and interpret. You know, you can take the vital signs and you don't interpret them for decisions, for interventions. So you go find the vitals were well taken. The pulse was up. Made an interpretation of the same. As you check on the tone, the woman should know, what am I feeling? Remember, we were saying as you massage, she has to feel that hard cricket ball-like, and you compare it with her forehead. So once she massages, she should be able to feel if whatever she's feeling goes hand in hand as the feeling that she gets when she touches her forehead. If it is not contracted, she will feel it is as soft as the tip of her nose. So she should be very keen to call out if that happens. Then when you still taking care of this woman, of course you will discharge her once she's very stable. How do you tell that she is stable? Of course, if she has lost a lot of blood and it is objective depending on the client, you can have a woman who came with anemia and even a loss of 200 mils of blood. That one to her is PPH because it affects her hemodynamically, and also just when you look at her physically, she's dizzy. She cannot be able to sit up, she cannot be able to breastfeed, she cannot be able to take care of herself. So you will only discharge this woman once you are very sure that that dizziness is all gone, she's able to breastfeed, she's able to take care of herself, she's able to walk around. And you will discharge her following the local protocols in our various facilities. Then for IV fluids, you need to adjust the rate. When you are still with her in the hospital, 1 liter over 6 hours. Remember, we have done the management of PPH. We did a quick infusion of 10 international units in half a liter of NS, going in about 10 minutes. Then now you need to put up the maintenance, which is in 1 liter, 20 international units of oxytocin to run over 4 hours. That gives you 1.5. So depending on how the patient is and the need to increase the volume in circulation, you will also look at the volume of fluids that you are now giving her. Then you also encourage her to hydrate, to increase her intake orally of fluids. And at this time she's able to walk, you will be able to remove the urinary catheter that you are using to monitor the urine output and as well to support her on output, and then to maintain oxygenation as required. Remember, this woman is bleeding, and when you're bleeding, you're losing what part of your blood? Yes? What are you losing when you're bleeding? the red blood cells that are very key in transportation of oxygen. So this woman needs to be supported with oxygen until she is stable. So you give as required and also as per the protocols that you use in your facilities. Then also remember this woman was bleeding. So when you are discharging her home, what HB level do we usually discharge them home at? Remember, probably you have transfused and you cannot allow this woman home before checking her hemoglobin level. Sini ukweli? Still, you know she could have bled and gotten an acute kidney injury. So you need also to run tests just to ensure that her kidneys are very much in order before you allow her home and she comes back to you now requiring to go for dialysis because her kidneys are completely injured. So don't release her home without doing a full hemogram on her to check on her HB level, to check on if she has infection also, and also to check how her kidneys are functioning before you allow her home. At what point do you discharge with a HB of how much in grams per deciliter? Remember, this is a woman who has gone through a lot. So when you're discharging her home, we've agreed she should be stable enough. And being stable enough includes having brought her HB to a reasonable level that she can be able to go home. Unless there is no blood for you to transfuse and her HB is at 7, that is still, is it a moderate anemia for her, or it is severe now she has delivered and she's breastfeeding? We need to support her with the iron supplementation, sawa sawa. So as per your local protocols in your facilities, she needs to be discharged on iron supplementation. She needs to be reviewed. I don't know how often do they come back to your facilities for review after you discharge them home and they had PPH. This is a woman, of course, you would love to review again, even in 1 week's time, to see how they are really doing, and you keep track on her. So you supplement, you teach them on diet, iron-rich diet, what they are expected to eat when they are going home. They need to take in the iron supplementation in order to boost their hemoglobin level so that they don't come back to you again requiring readmission and also transfusion. So what are we saying? She also needs psychological support. You know how PPH is a harrowing experience. And if this woman has just escaped death by a whisker, definitely she's emotionally unstable. So you need to bring in more people even to help you stabilize this woman for her to go home. Sawa sawa. So emotional support is equally important as we discharge her. Then what is important for us to take home from this training? That every second of uncontrolled bleeding risks a woman's life. Do we agree? Do we agree? Every drop of blood that woman is losing is pushing her closer to the grave. So it is very important for you to ensure that you swing into action very fast. Visual estimation is equivalent to blind estimation. We estimated there, and I told you I'm waiting to see how machometer itachoma. Ilichoma haikuchoma. Ilichoma haikuchoma. So when you fail to detect it early, definitely will delay interventions, or you will not intervene until it is too late. So visual estimation, blind estimation, and we should try as much as possible to do away with visual estimation. Then all elements of emotive approach should be delivered by, can be delivered by the midwives. Administration of tranexamic acid, you can administer it even without a doctor's prescription as long as you are managing the PPH. Massaging the uterus, we can comfortably do that. We can comfortably administer the other uterotonics in management of PPH. We know the dosages and the routes. We can quickly do IV lines access using the large bore and infuse fluids, and as well examine and escalate. The implementation approach to this, as you get out of this training today and go to your facility, how best can you try and implement this in your facility so that we save these mothers' lives? On-site multi-professional training with drills. This one can be done at the facility levels just to bring everyone on board, knowing PPH is a leading cause of maternal death, and we need everyone to be a team player. So we involve the doctors, the clinicians, the nurses, and even the support staff in our places. They know where the emergency tray is, and when you shout PPH, and you need that emergency tray, they'll go and get it for you on site. Sawa sawa. Then the use of a well-stocked PPH trolley or the carry case, that is the PPH tray. We can do that in our facilities for preparedness. We've said when you're preparing for every birth, equally prepare for PPH. No woman walks into the maternity unit with a label here that I will get PPH, sawa sawa. So we treat all of them equally. As they come to deliver, let them find you well prepared for PPH. And we will look at in the groups what you need to have in those trays. Then clinical leadership from medical and midwifery champions. Are we champions today because we are here going through this? Can we champion this implementation? Can you touch yourself on the chest and say, I'm a PPH champion? And one day I'll come to your facility and see how you do things around PPH. So you are a champion. So it starts with you. It starts with me so that we can be able to handle this animal PPH starting at the facility levels. Then frequent audits and feedback on PPH data. When we get these PPH cases, do we sit down to review them? See the gaps that are there, see what we can do, the action points, and recommend on some things that can be done so that we improve on the quality of care that we give these clients. And let the PPH data speak to you. Let it not be statistics as usual, but let you know that you have a role in just bringing change. Then it is important for us to note that emotive reduces severe PPH, which is expected also to reduce on the morbidity and mortality. Then investments in emotive will reduce downstream demand on health services like blood transfusions, intensive care treatment, and as well as operative interventions. And I work in a county where we are implementing this, and I can tell you it is, even the non-farms that you're using have really gone down because you are doing the right interventions. It has reduced operations in theater. It has reduced mortalities and also morbidity. So thank you so much. And I hope I was talking to champions who will champion change.
Thank you so much. Asanteni sana. We all agree that every second of uncontrolled bleeding is a risk in a mother's what? A mother's life. I know time is not on our side and we need to move with speed. So team, we are breaking for lunch, but first of all, I really want to acknowledge our online families. We are receiving your questions and you are working on them in the background. And please feel free to share the link, even to those people who are not with us. They can as well do what? Benefit from this. Again, there is a link that we are having on our tables. Please ensure that you register on that link. If you have a challenge, you can meet either one of us to assist you. So please don't go without registering on the link. And finally, before we break for lunch, I want us to go in our groups so that when we come back, we want to take the shortest time possible for our lunch break because we still have some other session. So when we come back, you know exactly the group where you are going to. We are going for a breakfast session after lunch. So we will go into 4 groups. Okay, fine.
The best that we can be able to do, yes, 4 groups, as she says. We would want to quickly say 1 to 4, and then from there, when we come back, we realize that most of us, we are sitting as a family. So we want to destabilize the family so that you can have another extra family, if there is something of the sort. Yeah, I know. So we can quickly start from this table, 1 to 4. 1. 4. 4. 3. 4. 4. Where is 1? 1. Hapana. 4. Nilikuwa wapi? 3, 4. Hapo. Fidel. Thank you. 1. 4.
Hello? Yeah, let's be out of our seats and move behind. Thank you. Yes.
Discussion.
small exercise before you leave. And the exercise is this. Who can remember where I said I work? Si wewe. Nani anaweza kumbuka nilisema nafanya kazi wapi?
Acha hiyo si live stream. Tufanye.
Nani anaweza kumbuka? Yes.
Achana na live stream.
Yes.